So my name's Emma Stavru and I'm the Occupational Health Clinical Wellbeing Transformation Lead. And today we've organised a Let's Talk Menopause session on bone health, understanding osteoporosis and thinking about what the risk factors are. And I'm really delighted to be joined by two fantastic speakers to present to us today. And we're really lucky to be able to benefit from their expertise on this subject. So I'll let them introduce themselves to you properly, but thank you and welcome Dr. Tiara Gill and Dr. Nuttan Tanna. Tiara.
Thanks for the invitation. Delighted to be giving this talk, which I think this talk's in two parts. I'm going to be giving the first half on just looking at osteoporosis, and I think Newton is doing the second bit, looking at sort of menopause and related issues around osteoporosis and menopause. Emma, I'm so sorry. Are you able to share the slides, because I can't seem to get that working? So if whoever doesn't know me, I'm one of the consultant rheumatologists in the trust. I work across this trust as well as Royal National Orthopaedic Hospital. Even though I'm a rheumatologist, I have a specialist interest in metabolic bone disease. I do a lot of work in osteoporosis on both sites. So today I'm going to just give really an overview of osteoporosis in terms of what it actually is. I think there's a little bit of confusion sometimes about what it actually is and what it means, why it's important in terms of the fact that it increases your risk of maybe fracture and how we assess that risk. And then the landscape for treatment has really changed in osteoporosis recently. So I'm going to be just touching on that, but it is a little bit of a complex area. So I'm just going to give an overview. I think my part of the talk is only 25 minutes. Is that right, Emma? So do alert me if I'm running over, but I'll try and keep to time. Okay, so next slide, please, Emma. So just firstly, just talking about what osteoporosis is. Prior to 1994, when the World Health Organization decided to operationally define it, it was just called brittle bone disease. So anyone whose bones broke was given a diagnosis of osteoporosis. And that wasn't actually as bad as it may sound, but because they couldn't maybe standardize, diagnosis and how you diagnose it, as well as treatments for it, they decided to make it a bit more of a concrete definition. And how they defined it at that time was that they said this is a condition where you've got low bone mass because the middle of the bone, the microarchitecture, is deteriorating to a point where it's weak and your risk of fracture goes up. So that's really how they defined it in terms of sort of conceptually. But then they said that if you measured a bone density of a person and it fell 2.5 times lower in terms of standard deviation statistically in a population below that of a young healthy adult, then you would have osteoporosis. And specifically, they said this would have to be a measurement of -2.5 or lower than the reading at the top of the hip, the femoral neck. So this is how they defined it. And since then, this is how we've been defining it. It's how we define it in terms of access to treatments, in terms of giving diagnosis. And so that is how we've been using it. This is an evolving definition, though, because nowadays we're realizing that actually just having a T-score definition isn't good enough. It doesn't capture other aspects of bone fragility. And that's a little bit more complex, but I think it's an evolving definition, and this is going to change in the coming year or so. Next slide, please. So why is it important? It's so common. It's the most common musculoskeletal condition that we have. 50% of women in their lifetime over 50 will sustain, unfortunately, a fragility fracture. And 1 in 5 men, so that's 20% of men, will also suffer a fragility fracture. It's so common. We know, though, that if you're going to get a hip fracture, which is a major osteoporotic fracture, you'll have probably had a previous fracture. So actually diagnosing earlier may sort of interrupt this sort of dynamo effect of getting one fracture or another if you capture it and treat it early enough. We also know that 50% of all fragility fractures are spinal, and that 2/3 of these are silent. So this has become a real focus of area in terms of osteoporosis management, in terms of trying to screen people for silent vertebral fractures, because we also know that if you've had one, you're more likely to get other types of osteoporotic fractures. So we're actively screening for it. This has a huge impact in terms of socioeconomic cost. And for us working within the NHS, this is actually quite a large burden in terms of bed days. So if you look at people coming through A&E, it's the second fracture, fragility fracture, as the cause for inpatient admission, is the second most common reason under pneumonia to be admitted via A&E, which is huge if you think about it. And this is in terms of money. You can see that, this is £1.5 billion per year. And that's just looking at sort of just NHS, excluding sort of social care costs. And in terms of bed days as well, it's taking a lot. Economic cost, a lot of people have to take sickness absence because of fractures, usually vertebral fractures because of back pain. We know this is a growing problem because we're obviously an aging population, so we do need to be screening for this more often. Next slide, please. So before I go on to talk about what osteoporosis is, I'm going to take everyone to what a normal bone is and what it looks like and how we physiologically remodel it. Remodeling is a natural part of our physiological processes within the body. The skeleton is not a bit of scaffolding, it's a dynamic organ. It's constantly being new tissue is being made, so new bone is being made and old bone is being broken down. And there's a couple of cells on this slide which shows you what is doing what. There are also two types of bone in the skeleton. There's cortical bone, so that's the bone on the outside, and there's trabecular bone, which is the porous bit of bone in the middle of the bone that you can see on this diagram, the bone that's got holes in it. And that's really important to understand because the treatments that we give, they treat different parts of the bone. And as I mentioned, the cells that are responsible for doing this in the body, there are osteoclasts which break down old bone, and there are osteoblasts which make new bone. And it's good to just have an overview of this because the treatments that we're giving sort of impact on different parts of this process. Throughout your life, this bone formation and bone breakdown process is balanced. And so your bone density is going to remain stable. Next slide, please. In osteoporosis, however, this bone remodeling process goes out of balance. And this is actually just part of natural aging as well. As we get older, we make less new bone, we break down more old bone, and so the net effect is our bone density goes down. So the outer shell of the bone, the cortical bone that you can see in this diagram, gets thinner, as well as the middle of the bone, the trabecular bone, that also starts to get thinner. The bones are not as strong, and then they're more likely to break. I have a lot of patients that come to clinic that say, my bones feel different, they look different. I know my osteoporosis is getting worse. Actually, osteoporosis just affects the middle of the bone. It doesn't actually impact on how the bone looks from the outside. So it's not going to change shape because of reduced bone density or osteoporosis. And that's important to understand as well. Next slide, please. There's lots of risk factors for developing osteoporosis. As I've mentioned, the most common one is age. It's going to happen as we get older. Unfortunately, as you saw from the statistics, women are more affected, and that's partly because we don't reach the same peak bone mass that men do, but also after menopause, we lose our estrogen, or estrogen levels gets low, and estrogen's a really, really good protective hormone that protects the bone from losing density. So when our estrogen levels drop, unfortunately, our bone density does too. Family history is really important, especially if your mum or dad have had a hip fracture in the past. And this is taken into account when we're assessing risk. Lots of other medical conditions as well as drugs can affect our bone density as well. And when we're looking at high-risk patients, we take into account these factors. It's not just the bone density that needs to be looked at, it's also other things that could increase the risk of fracture, such as falls. So certain conditions may make you, in terms of sort of stability may make you more prone to falling, such as Parkinson's, but there are other conditions as well, and we would take that into account and try and reduce the risk of falls to reduce the risk of fracture. Lifestyle risk factors such as smoking and now vaping is definitely implicated in reduced bone density. So we would encourage people to try and discontinue, and also moderate alcohol intake, because we know that this affects not just your general health, but also your bone. Next slide, please. So how do we assess fracture risk? Next slide, please. So a fracture risk assessment. I mentioned earlier, bone density is something that has been used previously to define osteoporosis, but actually the key thing is, what is your risk of fracture, not just what are your numbers. And in terms of the risk assessment for these are the things that we look at when we're performing a fracture risk assessment. So in terms of history, all the risk factors I've just outlined are things that we would be screening or looking at. And taking that information, we will then put it into maybe a fracture risk calculator. And the most commonly used one, and one that is recommended by our sort of osteoporosis guideline group, NOG, is FRAX. And I think Newton's going to take you through a few examples. I'm going to show you what FRAX looks like on the next slide anyway. There are other fracture risk calculators. GPs use Q fracture. And there's nothing wrong with that per se, but we do recommend using FRAX when we can. You might get a bone density scan or a DEXA, and that is the findings of that will also inform our risk assessment. We might wish to do some x-rays, as I mentioned, screening for spinal x-rays. That is something that we might request, and blood tests as well, looking at other causes, such as I mentioned, maybe a thyroid issue or low vitamin D that might be making your bones softer as well. So we'll be checking all of that with blood tests, and that also forms part of our fracture risk assessment. Next slide, please. So this is the FRAX tool. If you just Google FRAX, you get taken straight to the website. It's a global fracture risk assessment. You can see a Union Jack in the top right hand corner, because we're obviously UK based, and that's the one we use to assess patients from the UK. There is a bit of debate about whether we should be using someone's country of origin if they've migrated across, but this is an area of debate at the moment, so we're just using the UK based site. You can see on the screenshot that all the risk factors that I've mentioned are on there, and you would enter that data, and then it gives you a calculation of what someone's 10-year probability of major osteoporotic and hip fracture might be. And so that number doesn't mean anything. If you could press the toggle button, Emma. You get under also a NOG guidance button, and that translates it to this graph, and it will plot your risk on this graph in terms of what we think the level of risk is. So this is something that's part of a tool of assessing fracture risk, but we don't use just this just by itself. As I say, it's part of a sort of picture that we paint, and then we assess what we think we should be doing in terms of treating someone according to their fracture risk. Next slide, please. There's a new version of FRAX called FRAX Plus coming out, which some of the risk factors that you saw in FRAX, they're literally yes/no questions, and they're not very nuanced in terms of, if you're on steroid, for example, which is a drug that increases your risk of losing bone. It's, if you're on a high dose of steroid, it's going to be much more risky than, let's say, a low dose of steroid, and it doesn't have that as an option to enter in terms of what dose of steroid you're on the original FRAX, but FRAX Plus does. This isn't free for use at the moment, but it is going through regulatory approvals, and it gives us a much better fracture risk assessment, which is nuanced. So this is something that we're going to be using in the future. Next slide, please. I just thought I'd quickly show a DEXA scanner. This is a picture of a DEXA scanner, because people, when they say they're getting sent for one, don't know what to expect. It's not a CT scanner. It's not like an MRI scanner where you're going through a donut. Sorry, Emma, if you go forward. You're going through a donut. It's literally an X-ray, and it's actually a really low resolution X-ray. So the radiation dose is 100th of a chest X-ray. But you would be expected to get onto a couch like this. You might be asked, depending upon what scanner you've got, asked to sort of turn onto your side or not. But that's about it. That's all that's involved, really. So if you get sent for one, this is what to expect. We scan the hips and the spine because this is the areas of the body where bone density is likely to be lowest. And sometimes we do the forearm, but that's really only validated for patients with certain conditions. We would only do it, let's say someone's got hip replacements or the spine isn't easy to interpret. I always get asked about scanning intervals. Usually a normal scanning interval is about 3 to 5 years for somebody who's got risk factors. You don't just do a DEXA for no reason. You would have to think about whether there is a good indication to do it. And that is because you are getting exposed to radiation. We want to make sure we're not exposing you unnecessarily. And you know, in terms of intervals, whenever you get a DEXA scan, a report usually comes with it to say, given your sort of profile, we would recommend maybe another scan in X number of years. Some people do request sort of maybe annual scans, and that's not really going to be helpful because actually the changes on a DEXA scan are very slow because it's an X-ray. So minimum usually is 2 years. There are special circumstances where you might want to do it more frequently, but again, the DEXA reporter would be able to tell you whether you need one that's more frequent than that. Next slide, please. So just mentioned earlier that spinal fractures are something that we're really actively screening for because we think that they're a herald for future osteoporotic fracture. And this is the guideline written by the National Osteoporosis Guideline Group, which is our sort of main regulatory group and advisory group within the UK. And they actively recommend something called a vertebral fracture assessment. Emma, could you toggle again, please? And this is what it is. So when you go for a DEXA, you might actually get this as well, which is a spinal X-ray, if you like, from sort of the middle of your back down to the lower back. And that just gives us a really quick screening tool to see, is there any evidence of compression of any of the backbones that would warrant us thinking about this a little bit more in terms of treatment. But I just thought I'd outline that this is also now becoming actively done on most DEXA scanners. Some DEXA scanners don't, or services don't have access to this, but it's being rolled out, so more and more of them do. So you might be asked to do this too. Next slide, please. And in terms of what the results actually mean, you know, the numbers, as I say, sort of according to the WHO, this is what it means. If you've got T-scores in these ranges, you're either normal osteopenic or osteoporosis. And osteopenic is somewhere in between normal bone density and osteoporotic bone density. But it's just a guide and part of the picture again. And it, you know, the number itself, I might wish to treat an osteopenic patient who's had a major osteoporotic fracture because the number's not quite capturing their risk if they've already, let's say, fractured a hip. And we know actually even 50% of patients with osteopenia have a hip fracture. So it's not getting the whole picture, but it is part of our risk assessment. So don't get hung up on the number because whoever's looking at or requested the report should be able to interpret it for you and then explain what that means in terms of treatment or monitoring. Next slide, please. Other investigations I mentioned, blood tests, and these are the main things that we look at in blood tests. We look at your calcium levels, your phosphate levels, something called parathyroid hormone or PTH, your vitamin D levels. We always check kidney function because some of these treatments require you to have good kidney function in order to be able to give them safely. We check your thyroid function, also so maybe sex hormones if you're premenopausal or you're a man. So these are the main things that we check for. Toggle, please, Emma. There are new bone sort of markers of sort of what we call bone turnover that are being developed at the moment, but they're only for specialist use. But this could be a really exciting test in the future that we could use to measure dynamically what is happening in that moment. When I mentioned that DEXAs are slow to sort of monitor what's happening with bone turnover, this is a sort of up-to-date, if you like, dynamic marker in the moment on the day you measure it. So this should be an area that would be really good for monitoring what's happening with somebody's bones going forward, as long as we've obviously got it as a validated test, which it isn't at the moment, and so are only being used by specialists, but it is an area to watch. Next slide, please. So osteoporosis treatments, next slide, please. Okay, so sorry, this is a slide that I've taken for lectures that I give to medical students and doctors, but I've already introduced the concepts of bone building versus bone breakdown. So when we're treating, what we're actually trying to do is target these two processes. So if you could toggle, please, just once, thank you. So to the left of the screen are treatments that are available that reduce bone breakdown. And a lot of you are probably familiar with bisphosphonate treatments or tablet treatments that usually people are given first line when they're diagnosed with osteoporosis or if they've had a fracture. So these are mainly tablet treatments, but the treatments in blue are injectable treatments that are also available if you're having trouble or the tablet treatments aren't suitable for you. You can see HRT is part of that list as well. And HRT is now being is having a resurgence in terms of sort of popularity, but also in terms of evidence. A lot of people were obviously scared about HRT a few decades ago because of risks. But now we're finding that in the under 60s, if you've got risk factors for osteoporosis, and you're around the time of your menopause, HRT could be a really good first-line treatment for you if you haven't got just severe osteoporosis. And we are actively promoting that now. So that is something that in the last couple of years is becoming sort of more common, that we're saying consider HRT for somebody under 60. Toggle again, please. Thank you. And then on the right-hand side of the screen are drug treatments that are available for bone building. And all the treatments that are in blue are injectable treatments. These treatments are also self-injection. So these two are injectable treatments that build up bone quite nicely. Toggle again, Emma. And we've got a third injectable treatment, which also builds bone. It's probably the best bone builder we've got out of the three of the bone building treatments, but it also helps stop bone breakdown a bit. And so that's why it sits in the middle. Toggle again, please. And again. These treatments that are in the circle, sorry, go back, thank you. These are self-injection treatments though. So the ones that are blue that aren't in the circle, they would be administered by someone else, whereas the ones in blue are self-injection treatments, but they're very good bone building treatments, and we're using it for patients who are really high risk of future fracture. And we do that risk assessment in the way that I've described earlier. Next slide, please. Something I just wanted to discuss, because it's a very common question I get in clinic, which is this all sounds great, all these treatments sound amazing, but I'm really worried about the side effects of this and side effects of that. And obviously that's fine for everyone to make their own decision about what they feel comfortable taking or not. The only thing I would emphasize is that if drug treatment has been recommended, a risk assessment has already been done around side effects, benefits versus risks. And at the point that treatment is recommended, benefits are outweighing the risks or potential side effects, because not everyone gets side effects either. And one of the side effects that I think a lot of people get really worried about is dental issues. And I mean, I was at a national meeting last September with other metabolic bone specialists around the world, and the discussion was all about this rare side effect called osteonecrosis of the jaw, which is associated with any of the drug treatments that stop bone breakdown. And a lot of people don't take them because they're worried about their teeth. Actually, it's nothing to do with the teeth. It's only the jawbone that there can be delayed healing of. And even then, it's such a rare side effect. I mean, we've given these treatments are given to hundreds of millions of people around the world. The incidence rate for this side effect is so low. I could count on one hand how many patients I've seen with this, and I don't think it was just the treatment. So that this consensus sort of recommendations are that it's been overstated. And a lot of you may have gone to your dentist and they also expressed concern about this. I do think it's also been overstated to a lot of the dental community, so they get really worried as well. I would always advise, if you're concerned about sort of the dental side of things, ask your GP, ask your specialist the question about what is my risk, and talk it through, because someone has only recommended this treatment really for you because they think your risk of fracture is much higher than this nominal low risk of osteonecrosis of the jaw. So I would just emphasize that, because a lot of patients I know get very concerned about it, and then they don't take treatment which actually would have benefited them, and then they come in with a fracture which potentially could have been prevented. So I just wanted to make that point. And any treatment that you start as well can always be reviewed and stopped if needed, but it should be done under the guidance of a practitioner. And I'd actively encourage everyone to ask questions if they are uncomfortable about it. And if you still feel you don't want it, that's fine too. But at least you've made an informed decision. I've just included a picture here of what the bones look like. This is a sort of 3D sort of scan at what bones look like after 1 year of treatment with romosozumab. And that is phenomenal. It's obviously osteoporotic on the left, and then it's actually not osteoporotic within a year on this drug treatment. So there is real changes that we can make with the treatments that are available now. Next slide, please. Okay, and then we shouldn't be just focusing on sort of drug therapy. There are so many things we can do to optimize our bone health in terms of our diet, supplements. There was a debate around calcium supplements and whether they were safe or not a few years ago. I tend to say if you've got a good balanced diet and you don't have any issues with regards to sort of absorption, then your diet should be sufficient in terms of calcium intake. If you find that you're not getting enough, then yes, top up with a supplement. However, I am militant about vitamin D. I saw something sent to me yesterday. I think it was published in the Daily Express of a doctor who'd said that actually people are overdosing on vitamin D, or potentially are, and they should be careful about it because it alters calcium metabolism. I am not sure where that person has got their information from, or in what capacity they're speaking. Unfortunately, I see a lot of people that are deficient in this country, and I would recommend, if you've got some bone issues, you should be taking 800 to 1,000 units daily, and I'm militant about that all year round. Unless you're advised that you've got a medical condition, which means you need to be cautious about it. But if you've been recommended to take it, take it. Exercise is so important. Weight-bearing exercises, muscle strengthening exercises. If you've had a fracture, I know that can be worrying for people, especially if it's spinal. But there are lots of resources to show you how you can do that safely, because it's really, really important for your soft tissues as well as your bones that you carry on exercising. I've already mentioned the lifestyle modification in terms of smoking cessation and moderating alcohol, and falls assessment I've also mentioned too, and you should have a falls assessment if you're having more falls than 2 a year. Next slide, please. Okay, so a few other sort of myths or things I just want to counter, that sort of common questions I get or comments I get in clinic. Osteoporosis is completely painless. You don't know when you can't feel when your bones are getting softer. You can't feel if the drugs are working and they're getting better. So treatments are not going to relieve your pain, because osteoporosis doesn't cause pain unless you fracture. So that's a really, really important point that I just wanted to sort of share with you all. A lot of people don't take alendronic acid, or don't want zolendronic acid, because they're worried about the acid term within it. But all the acid means is that it's just belongs to a group of drugs or chemicals that are in the acid classification. Most of you might or may not know that ascorbic acid is actually vitamin C, but people take that regularly and not worry about it. So I would also say, again, if you've got concerns about the names, just discuss it with your prescriber, but not to be scared of something in terms of these drugs because they're called acid, because it doesn't mean that they're going to dissolve you. I've already mentioned healthy lifestyle is important, but I do get commonly asked, if I increase level of exercise I'm doing, if I have a better diet, will I be able to manage my osteoporosis? And I think we should be doing that for our general health anyway, but it isn't going to significantly reduce your fracture risk if you are in a high risk category. So again, it's people's prerogative what they choose to do, but I do think that if you've had a fracture, you may well, a fragility fracture at a major osteoporotic site, you may need a bit of extra treatment. I've already mentioned exercise important, and reducing falls risk by doing all of these things, making sure your footwear is good. If you're unsteady, that you do use something to support you, and doing the types of exercises that help with balance as well as strength. Next slide, please. So I'm going to be finishing off shortly, but I thought I'd just signpost you to some online resources that are really, really good. And the Royal Osteoporosis Society leads on this. They've got their website is excellent for all sorts of information in terms of nutrition, in terms of exercises if you've fractured, as well as all the drug treatments I've talked about. And it will give it all in much more detail than I've just talked about because I haven't got time to go through it all today. So do visit the Royal Osteoporosis Society website, and it does actually have a risk calculator now as well. So you can plug in all of your personal details and it will calculate a risk in the sense that whether you are somebody who should maybe be discussing this further with your clinician. Next slide, please. They've also got lots of webinars if reading isn't your thing, so you can go on there and you can just watch a webinar as well, and they're just as good. Next slide, please. And they've also got this Bone Med Online, which has been now online, I think, for about a year, which helps if you've got, let's say, treatments that you need prompting for, vitamin D, or, you know, your bisphosphonate, whatever. It actually sort of sets up it's an app that basically prompts you to do the things that is part of your treatment program, and that includes exercise too. So again, anyone can register for this, so do have a look at that. Next slide, please. Yes, I think I've already touched on this. Next slide, please. Calcium supplements I've just talked about briefly, but there is an actual calcium calculator on their website as well. So you can, again, enter sort of maybe your sort of average diet in a week or in a day, and then it will calculate for you if it looks like you may need to supplement that or you're getting adequate amounts. So this is a really useful tool as well. Next slide, please. And then the Royal College of Physicians, the RCP, have something called a fracture liaison site database. And this, if you just Google that term, RCP FLSDB, will come up with loads of other resources as well if you want to look into osteoporosis in a bit more detail. Next slide, please. So these are screenshots of the types of resources that they have on there for patients as well as clinicians. Next slide, please. And more. So there's so much online that people can access if they need to. Next slide, please. And if you're really wanting something in depth, then you can read our Bible, which is the NOG guidance, which was published about 2021, but then updated a couple of years ago. Really in-depth advice about assessment and treatment and management of osteoporosis. So if anyone's really interested, they can go and have a look at that too. Next slide, please. I think that's me done. So I'm very happy to take questions, or I don't know if you want to move on to Newton's presentation.
So much, Tiara. Yeah, we will swiftly move on to Nuttan. There is one question in the chat that I thought might quickly bring up. It's sort of in two parts. Genetic components to osteoporosis and whether it's something we can inherit a disposition for, and also individuals with black skin tend to have vitamin D deficiency in the UK and then contribute to increased risk of osteoporosis.
I'm so sorry, Emma. I wasn't able to hear that really well. Are these questions that are in the chat?
Yes, they are in the chat. Sorry about my audio.
Sorry, no, it might be me.
Is that any better?
Yes. Now I can see a question. I can answer. That's much better.
Yeah.
Thank you. I can see a question. Is osteoporosis inherited? Number one. It's not so much about inheritance, but we do think there's a genetic component to it. So if you've got especially immediate family members who have extensive history of fractures or early fractures, and especially, as I mentioned, parental hip fracture, that is definitely been demonstrated as strongly correlated with sort of future fracture risk for you as an individual. But you know, osteoporosis is a multifactorial condition. As I mentioned, it's about all sorts of things. It's not just your genes. So there will, you know, it's not just a sort of straight line connection or correlation, if you like. There is a genetic part to it, though. So yes, we do take that into account. And then the second question is, with black and brown people being more vitamin D deficient in the UK, does this contribute to more being diagnosed with osteoporosis if they are susceptible? I mean, that's a really good question. But actually, what's really interesting is obviously I do DEXA reporting for patients who have their DEXAs in this trust, and given our population, we've obviously got a lot of patients who are black or have brown skin, and that some of them have very low bone density, but they don't fracture, and so it doesn't always correlate. So as I said earlier, there's a lot of factors involved in why you might be fracturing. That doesn't look like necessarily you're going to just fracture more because you've got black and brown skin, and that means you're vitamin D deficient. I don't think that it's as easy as that in terms of drawing conclusions. But yes, it's definitely one of the secondary causes. So we do need to make sure people are vitamin D replete and they've got adequate levels and are taking supplements. So as I said earlier, I strongly advocate that. Was there another question, Emma?
No, that's it. Thank you. Lovely. Thanks so much, Tiara. I'm really sorry if anyone's having trouble hearing me. I will keep doing my best. Nuttan, would you like to introduce yourself in case anyone doesn't know you, though I'm sure they do?
Okay, thank you, Emma. Thanks for the invitation. By the way, Tiara, that was a brilliant presentation. And I'm so happy that I work with you on Tuesday afternoons in the Metabolic Bone Clinic. So by way of introduction, my name's Nuttan Tanna. I'm a consultant pharmacist. I have an interest both in menopause and osteoporosis, and I run medication management clinics with both services. What I thought we would do is, Tiara's given you a brilliant background. What I would like to do is run through 2 cases from my clinic. And actually use that to demonstrate some of the discussion that we have with patients. I mean, just as a starting point, if I see a patient who's been referred in my clinic, it's actually doing a risk assessment. And today I'm going to focus on osteoporosis. But remember, I look after menopause patients as well. So I'd be looking at menopause management as well. But the whole idea is to work with the patient, provide them with all the information that they need about their risks and benefits, to take them through the various treatment options that they have, understand what their concerns are. But it's actually at the end of the day a shared decision making. And the management plan that we usually work up is actually looking at what medication we're going to provide, how is that going to be used, but in addition, what are the lifestyle interventions, etc., etc. And I want to use the FRAX tool. I was talking to Emma about it. So we're going to run these 2 cases and we're going to complete the scores on the FRAX tool, but it actually opens up the discussion about the lifestyle interventions that need to be in place. And Tiara's given us a brilliant starting point. Emma, would you like to share the FRAX tool? And then we'll do the first case from my clinic.
Yeah. Let me share this. Okay, can everyone see that? Yeah.
Yeah, that's fine. Your audio is a bit tough to cope with, but I guess I understand. All right. So basically, we've got this FRAX tool that Tiara's kindly mentioned. The latest version, you have to put the continent, so that's Europe, the country UK. So we are clear in our minds that we are dealing with the population in this country, and then we start populating this. And in this sort of scenario, when I'm just doing a basic risk assessment, the patient doesn't necessarily have had a DEXA scan, so I may not know any information with regards to their osteoporosis diagnosis. So let's start. Age 42, remembering that this is validated for patients between 40 and 90. Sex, female. Weight, the patient that I'm thinking about, she was 65 kilograms. And her height was 154 centimeters. She did not have a previous fracture, so it's no. But her mother had, when we were doing her assessment, she reported that her mother had a hip fracture. So we ticked that. And then she told me that she was smoking. So when it came to lifestyle intervention work, she smoked 10 per day, not on steroids, not on rheumatoid arthritis, but just to everybody listening, these are the particular scenarios where the risk is high. So if you're on steroids or if you've got rheumatoid arthritis as a medical condition, that would be an independent risk factor. Secondary osteoporosis, for this patient, we are going to say no, because basically she didn't have any other medical conditions. She was actually 42, doing all the right things, going to the gym, etc., etc. So essentially, the only reason why I wanted to think about FRAX was because she was 42 and she was being seen in the menopause clinic because she was perimenopausal. She was already starting to show signs of erratic bleeds. So maybe she's missing out on some of the estrogen protection that Tiara talked about. And I just actually, as soon as she said she's going to the perimenopause, can I help her with the treatment options? But then she talked about her mother with a history of hip fracture. It was worth actually looking at the FRAX tool. And of course, as you explore it, then came up the information that she's a smoker as well. Now, remember, I haven't got a DEXA scan. We will press the button calculate. And it says that her BMI is 27.4. So that's already telling me that she's a little, we need to do a little bit of work when we think about weight, but she's in the overweight scenario. And many patients want actually a helping hand, just talking about it. It makes them a bit more comfortable. 27.4, but she was doing all the right things. So I wasn't too worried. I just said to her, maintain it. Let's look at it in that context. But this is here, this is where the FRAX tool is now saying that this patient who's 42, her 10-year probability of a fracture, if you're looking at major osteoporotic fracture, is 5.2% and hip fracture is 0.2%. And generally speaking, when I look at that, I think to myself, if I give her some advice, she should be all right. But then we look at the NOG guideline. So if you click NOG guideline, it says before you advise this patient and say just carry on with good lifestyle, etc., etc., and maybe in her scenario she may start on HRT because she's struggling with symptoms because she's got the erratic bleed pattern. The NOG guidelines is telling us that this patient needs to have a DEXA scan, because actually the DEXA scan will add in some more information and give us a more realistic view of what her future risk is for fractures. So this patient in my clinic, we automatically referred her for a DEXA scan. Remember, at this time, DEXA scan, there's capacity issues, there are protocols. We have to make sure that we are referring the right person for a DEXA scan. So, for example, just to work on this case, if this patient hadn't been perimenopausal, so showing signs of losing estrogen protection, and she was doing all the right things from when you think about from the lifestyle point of view, and if this had come up in the green, I would have just said to her, listen, you're doing all the right things. It's just lifestyle intervention work. Let's make sure you're cutting down on smoking. Let's think about what you're doing at the gym. Are you doing muscle resistance exercises in addition to weight bearing? Weight bearing, important for maintaining bone density. Muscle strength, important where you do the resistance exercises. So this is how actually we would work with the patient and actually come up with a shared decision making. But this conversation, and I have had lots of feedback from my NHS clinic, the patients feel that they've actually been given some information that they can understand, they can actually take some steps forward, and they know exactly what the risk benefit is if they are deciding to take treatment. And in this sort of scenario, this particular patient, we actually looked at HRT risks and benefits. And although it's not part of this presentation, just as a quickie, if anybody wants to look at risks and benefits of HRT, just as information, the patient information leaflet that we use, you can easily download it. It's the self-care forum. So you go on the website, self-care forum, download the menopause fact sheet, and it's the current patient information leaflet that we provide to our patients when we're looking at HRT risks and benefits. So I'm going to leave this case here, and if Emma, we could go back and repeat the exercise with another patient case. So the case number 2 was another patient that I saw. By the way, the 42-year-old was Caucasian ethnicity. This was a 60-year-old Asian patient. So 60 years old, female, weight 60 kilograms. Height 158 centimeters. She had a previous history of fracture. So she told me that at the age of about 54, she'd slipped and had a wrist fracture. She thought it was a hard fall, but she still had a wrist fracture. And when she mentioned the age 54, even though it's a hard fall, she's 54 and she started to go through the menopause and lost, in my mind, from a health professional point of view, she'd already started going through the menopause. And we do know that many patients will present with a wrist fracture. There's good data to say that after going through the menopause, a woman may present with a wrist fracture, but she's the one who's more likely to go on when she's over the age of 60 with a vertebral fracture, so that's a spine fracture, or if she doesn't get a vertebral fracture, or if it's not picked up, then over the age of 70, she will have a hip fracture. So this is where you're now looking at a history of fracture and trying to work out how it fits in for that patient scenario. So there was a previous fracture, history of wrist fracture, hard fall, but it was after the menopause, so therefore I ticked yes. No, she didn't have any family history of fracture. She was not smoker. She did not smoke, but she had been on steroid courses. Now, here I have to be careful because Tiara will correct me. She wasn't on a regular tablet dose of steroids, which is where we pick up immediately that would be a risk factor. What she was presenting with was asthma, and perhaps she had been told by her GP it could be COPD, which is obstructive respiratory disease, but she was in inhalers, and those inhalers, the brown inhaler, for example, is how she explained it, was one that had steroid doses in it. So I decided to click glucose steroids. What I'm being here is very clear. The evidence base is very strong. If you're on oral prednisolone or steroid treatment long-term for more than 3 months, that is a definite risk for fragility fracture. But I'm looking at this patient and trying to make up my mind, given the fact that she's got asthma and she's been on steroid inhalers for a long time. So I'm taking this as just to give me an idea of what her risk factors are. She does not have rheumatoid arthritis, no other medical condition, so there's no other secondary osteoporosis risk. She does not drink alcohol, and I haven't got a DEXA scan, but I'm going to calculate her score to see how that would help inform our management plan. And guess what? BMI 24, so reasonably healthy. 10-year probability of fracture, not reasonably healthy. That is healthy, by the way. I'm going to correct myself. But then the 10-year probability of fracture, major osteoporotic fracture, 20%, hip fracture, 4.9%. And I'm thinking to myself, 20%, I need to think about this. Let's see what the NOC guidelines are telling me. And that's put her in the column where we need to treat. So here, there's a principle, and in fact, I would go and discuss it in the MDT with Tiara, with Dr. Hogarth. We would present this case. It says treat. So even though we might order a DEXA scan, we are not going to wait for the result from the DEXA scan. We are going to make sure that this patient's been offered treatment choices. And Tiara's given you the whole list of all the options that are available. She's 60, so I mean, if there was a menopause element, 60 is a bit too late to start HRT, but there are certain patient scenarios where we will start HRT. But here, in this sort of scenario, the bisphosphonate would be a good option, and we would explore those options or alternative osteoporosis medicines with that patient. So I'm hoping that just these two cases will give you an idea of the shared decision-making process in the NHS clinics, both in the osteoporosis clinics when I'm working with Tiara or Maxine, or on the Thursday morning when I'm running the NHS menopause service. And then, of course, I will add, we've also got our menopause staff support service. Now, the menopause staff support service is a brilliant initiative. The feedback has been tremendous. We've won a couple of awards as well. But coming back to the service itself, it's where we provide support for members of staff working at London Northwest hospitals. You have to complete a form because we only want to see you if you're going through the menopause, or if there's some scenario which suggests that there may be an issue and we need to speak to you about menopause management. But in that scenario, we are also looking at osteoporosis management. We want to see you. We provide support. We give you the information, and I will talk to you. And Mariam Nazri is the other menopause specialist who works with me in the Occupational Health Staff Support Service. We will provide information, getting the member of staff ready to go and speak to their GP about the treatment options or the the broader management plan that they want to consider, but where the GP will support them. So having given you that background, I'm going to stop there. Emma, thank you so much for helping me with the FRAX tool. Let's open it up to questions. And both Tiara and I are here to help with question and answers.
Oh, Brill, thank you so much, Nuttan. That's excellent. Does anyone have any questions? Either pop your hand up or feel free to type something in the chat. Thanks, Peter. Lovely to have you with us. Shayla.
Hi, sorry I can't put my camera on, but my question is, how do I, given everything you said, Nuttan, how do I go about being referred for bone density measurement? Does it happen through the GP, or what sort of things will have to be in place? Because I popped out a few times for you to have a referral for bone density.
Adesola, thank you for that question. What's your background? Are you clinical or admin?
Non-clinical.
Okay, so if you're clinical, then I would feel comfortable saying, why don't you Google the FRAX tool, complete it for yourself, because you'll know what your information is. You'll know you're not a smoker or what other medical conditions you've got. If that gives you an idea that you're at risk, then I would download that leaf, the NOC guideline, that report, and take it to your GP and discuss with your GP. And that means that your GP will decide whether he needs to refer you for a DEXA scan or not. The other way to do it would be where I'm assuming you're asking this question because you actually feel that there is a risk factor in your history. If that's the case and you want to speak to one of us in the Menopause Staff Support Service, which is the service for staff, then perhaps you could book in an appointment and we can discuss it together.
I have an appointment in the past, but we didn't have a conversation around that. And I know that we haven't started taking second appointments, but am I able to book a follow-up appointment?
Guess what? Emma's nodding. Yes, we've broadened it up because we've realized we've had feedback that staff members really feel that they may want to come back with some for a follow-up review. And very happy to see you in that context.
Fantastic. Thank you very much.
Welcome.
I just want to add in there, you know, if you're not comfortable using the FRAX tool, and you do need to be a little bit careful about how you get that later on there. I showed the screenshot for the osteoporosis risk checker on the Royal Osteoporosis Society. Anyone can use that. It's really useful. And it actually gives you the risk assessment at the end of it, saying, you need to maybe take this to your GP or to somebody else to look into this. So do use the ROS tools as well, because they're really, really intuitive, straightforward, simple to use.
Thank you.
Thanks so much, Shayla. Thanks everyone for answering. As a physio, I'm also going to promote ROS have really good YouTube videos about exercises as well. So as a physio, I'm always going to promote exercise. So that's there. As Tiara highlighted, all the other things they've got on the website as well. But they've got those exercise videos as well if you want to just look at somewhere to start with a bit of strengthening to support yourself. We've also got a question in the chat from Martha. Thank you. Does having a high BMI increase your chances of having a bone problem?
Does it increase your chances of having a fracture? Obesity or like high BMI it's complex. It's not a straightforward answer. I'm so sorry, I can't be straightforward about it. Low BMI is definitely associated with having lower bone density. So that's under 18, a BMI of under 18. Higher BMI, there's a bit of more of a complex relationship. It depends on the reasons for it. So diabetes, for example, has been highlighted as a risk factor now, independent risk factor for increased bone fragility. So if you've got, you know, insulin sort of resistance problems, that means that your weight is higher as well, then that could be a risk factor for having sort of softer bones. I think it's complicated. There isn't a clear thing with high BMI, but I think it depends on the reasons for it. If it's thyroid dysfunction, diabetic or sugar control, then there may be a link. Does that answer your question, whoever asked that?
I think so. It sounded good. As always, things are nuanced, aren't they?
Yes.
Perfect. Does anyone else have any more questions? While you're thinking, I have just popped a few links in the chat to make reference to some of the things we've talked about. So if you want to book a support service appointment, either to discuss anything to do with menopause, but also thinking about discussing your risks of impaired bone density in menopause. And then just some of the links Tiara spoke about, I've popped in the chat. And if everyone could please fill in some feedback for us. We need feedback so we can keep running these events and hopefully make them look like what you want them to look like and answer the questions you're interested in. I can't see any other. Oh, Nuttan, go for it.
I just wanted to say thank you to Tiara. She's given up some of her time, and I know how busy she is. So Tiara, thank you very much for accepting this invitation to present today. Guess what? I listened to your presentation and I've refreshed myself as well.
Always good to talk. I love talking. I love talking, Newton. So
oh, there you go, people. Tiara likes talking. That's lovely. Thank you.
That's dangerous. You're going to get roped into more things.
Yeah. Happy to come back if you need me.
Excellent. We'd love to hear that. Well, thank you so much, both of you. And thank you everyone for attending and contributing and helping to build lots of ongoing positive menopause culture at our trust. So thanks everyone. Enjoy the rest of your day. Bye.